Good morning, and welcome back to the Global Neurosciences Institute Grand Round series. And now it is my great pleasure to introduce and reintroduce our speaker, Dr. Ausim Azizi. Dr. Azizi received his MD and PhD degrees from Southwestern Medical School in Dallas, Texas, and completed his internship in neurology residence at Yale New Haven Hospital. Dr. Azizi is board certified in neurology, neuroimaging, and neurocritical care. He's an active clinician and a fellow of American Neurological Association and Philadelphia College of Physicians. He has been elected as top doc by Philadelphia Magazine for 14 years. Dr. Azizi was trained as neuroanatomist and neurophysiologist, published a body of work on neuromorphology. Later, his lab pioneered exploring bone marrow stem cells to treat neurological disorders. He's a reviewer and editor on multiple neurosciences journals. He has received many teaching awards, including Russell and Pearl Moss's teaching, and as well as Golden Apple Award at Temple. And he was granted a visiting professorship at the Mayo Clinic and the University of Pennsylvania. Currently, he's the neuro-immunology specialist at GNI. Dr. Azizi will be speaking today about multiple sclerosis. Dr. Azizi.
Thank you, Peter. I almost didn't recognize myself in there. I'm going to talk to you a little bit about multiple sclerosis. And as I was trying to prepare this talk, I realized I am digging more and more into just general immunology rather than neurology. But it's a good thing to open our eyes from neurology and look at other disciplines as well. So at the beginning of this talk, and by the way, I do not have any conflict of interest or effort, I will make some definitions at the very beginning, talk about the epidemiology and etiology of multiple sclerosis. I will talk a little bit about the clinical presentation. And then the last half hour or so, we're going to talk about pathophysiology and treatment of multiple sclerosis. In terms of definition, MS, as you look in any textbook, is a chronic inflammatory demyelinating disease of the central nervous system. A neuroimmune disease usually is a neurologic disease that's either triggered or maintained by inflammation. This inflammation can be gross, the classic tumor, calor, rubor, or it could be at a molecular level that we don't see very well. So MS contains both of these types of inflammation. MS is triggered and maintained by the inflammation that comes on. And also some other diseases are triggered by other things. For example, Parkinson or Alzheimer's are triggered by protein misfolding, but they are maintained by inflammation. Examples of inflammatory diseases that primarily affect the peripheral nervous system are, as we know, myasthenia gravis and Guillain-Barré syndrome. Why is multiple sclerosis called multiple sclerosis? If you take the brain of a multiple sclerosis patient, which is what was done in the late 1800s by Charcot's group and La Salpêtrière in France, you will see a brain that is depicted in the right side here. And this brain looks like, instead of the white matter, which is I'm showing with the pointer here, has these gray, darkish, brownish, finger-like projections. These finger-like projections are also called Dawson's fingers, and they are indeed looking like fingers. And if you push at them, when you take the brain out immediately, they are hard. So because of that, they are called multiple sclerosis or sclerae on plaque. So the name multiple sclerosis came out because of these sclerotic that are located in the brain. The systemic and neurologic immunity have a very complicated interaction or dance between them. The interaction between the brain and systemic inflammation or systemic immunity, which is your B cells and T cells and so on and so forth, is different compared to the interaction of the immune system with other organs. It is delayed and it is selective. And the reason for this delay and selectiveness is that it is because of the blood-brain barrier. Blood-brain barrier was recognized in the 1960s and designated brain as an immune privileged areas where all the chemicals that are causing immune problem do not get to the brain, and as a consequence, brain is a privileged area. That is not 100% true. What happens is that there is a delay and there is a selectiveness of these immune chemicals from the periphery that can get into the brain. Within the brain itself, there is a very robust innate immune system that is driven by microglia, by astrocyte. There are a ton of immune chemicals that are produced by the brain, and also even neurons participate in the immunity and rebuffing chemicals from the brain itself. A framework of a neurologic disease that is triggered and maintained by immune system can be described in this picture. There is a trigger that comes on. This trigger could be any biological trigger of a protein or a virus or a bacteria. The acquired immunity or peripheral immunity, which is the blue circle, and the brain immunity will interact with this antigen. And the consequence of that is going to be encephalomyelitis, demyelination, inflammation, and then at times even degeneration. So we're going to talk about this whole thing in a little bit more detailed. What about epidemiology of multiple sclerosis? Well, compared to a lot of diseases such as a stroke, where we have 900,000 new strokes per year in this country, and MS is not by numbers that high, but it's a chronic disease. So people who have MS, they stay with MS for the rest of their life. And they start getting diagnosed with MS at a very young age. So currently there are about 145 to 170,000 people who are diagnosed with MS in the US. It's a disease of the young people. The age of diagnosis is usually around 15 to 55 years old. If somebody is over age 50, and the first thing in the differential should not be multiple sclerosis. And there is a preponderance of female to male. So females have more of, in other words, more number of females, 2 to 1 to 3 to 1, get multiple sclerosis compared to males. The prevalence was about 1 to 100,000 in the equatorial area and up to 30 to 100,000 and areas that are away from the equator. So if you look at this map of the world, and this is equator, in these northern areas like Sweden and Northern Europe, there were 30 to 100,000. I keep saying were because this is the statistics that was from 1980s and 90s. And the mobility of population has quite a bit increased since then, and there is a lot of mixing up of people from different areas, from the equator to the temperate area and from temperate to the equator areas. Also, epidemiology can tell us about the risk factors, what are the causes of multiple sclerosis. We have found a large number of things, but not a definitive molecule that would say, okay, this is the trigger for multiple sclerosis. These number of things can be divided into genetic factors on the left and environmental factors on the right. The genetic factors could be familial aggregates, HLA, BR, there is interleukin receptor, and then there are a number of other genes for like CD17 and so on and so forth. But none of these, if you do a GWAS analysis of all the genetics of patients with MS and compare it to normal people, you're not going to find 1 or 2 or 3 genes that are going to stand out and say, oh, these are the causes or the perpetuator of multiple sclerosis. Environmental factors, on the other hand, abound. For example, viruses have been touted as a cause and also as a maintenance of MS. In Philadelphia, every 20 years, there is a new virus that's introduced as cause of multiple sclerosis. The latest one was Epstein-Barr virus, as you may know, and I'll come to that in just a minute. And there is a concept of what's called infantile hygiene hypothesis, where kids or babies who are clean and fussy, they will get MS more often than kids who are left to crawl on the ground and be exposed to antigen. Smoking definitely makes the symptoms of MS worse. Diabetes, high salt intake, and lack of vitamin D are the other things. These in general are not causative agents. In other words, they don't cause multiple sclerosis, but they play a great role in maintenance and also in exacerbation of multiple sclerosis. What about progression of MS? Is MS a homogeneous disease that once you get it, you're going to remain the same? The answer to that is no. The progression of disease is relatively heterogeneous, and there are 4 formal types of multiple sclerosis that has been defined. And the progressive relapsing MS, if you look at time, which is going to be in the x-axis, and disability on the y-axis, you see that people who start with diagnosis of multiple sclerosis, they can go up and down and continuously progress. These are called progressive relapsing. There is secondary progressive, where at the beginning, the patients start with remitting relapsing, and then finally they become a smoldering disease that continuously progress. And then there is primary progressive, where there is no relapses in the disease, and they will have these plaques building and going away in the brain. And also clinical presentation is more kind of in a relapsing. Most of these have to do with the location of where the plaques are. If the plaques are, let's say, located in the internal capsule, obviously you're going to have very severe motor and sensory deficit. But if they are more in the frontal lobe and the occipital lobe, you're not going to get sensory motor deficit, so you're going to have a primary progressive. And then finally, the more important one is relapsing remitting. And relapsing remitting is not necessarily the largest number of patients with MS, but because this is the easiest way of looking at drug trials. In other words, if someone has relapsing remitting and they're relapsing 4 times in a year, and you give them a medication and they're relapsing only 3 times a year, you have a quantitative analysis of the drug efficacy, as opposed to something like this, where defining and quantifying it is going to be very difficult. Another aspect of multiple sclerosis is disease severity. In terms of severity, the disease comes in 3 buckets. People can have mild MS, and these patients have a few plaques and a little bit of deficit here and there, but they live a pretty normal life. The second bucket is moderate disease. The moderate disease are using assistive devices by age 40. So a cane or a walker by age 40 because of multiple sclerosis, that's a moderate MS. And then there is the last group that is fortunately a smaller number. This group has reasonably poor prognosis, in the sense that by age 35 or 40, they are already using a wheelchair. And these are what we call as really bad MS. Usually they are diagnosed at an early age and they progress rapidly. Some of this may be neuromyelitis optica as well. What about clinical presentation of multiple sclerosis? What does it look like? Is it the same as stroke? Is it the same as other neurologic diseases? The answer we could get from this very nice case
that we saw at Crozier-Chester about 2 years ago. A 31-year-old woman presented to CCMC with complaint of left leg weakness, loss of balance, and right arm clumsiness. Left leg symptoms started about a year ago. It gradually improved, but it recurred recently. A year ago, they did an MRI and showed that her L spine was normal. 3 years ago, she had an episode of blurred vision in one eye, but that improved over a period of 6 weeks. And then a brain MRI during this visit showed that there are multiple lesions in the brain with white matter and in both hemispheres, and there are contrast enhancing lesions as well. So these are some of her MRIs. They are very typical. Dawson's fingers jutting out from the surface of the ventricle, for example, that one or that one. You can see a contrast enhancement in the form of a C. So this patient was diagnosed with multiple sclerosis. And what did we learn about MS clinical presentation from this patient? Well, we learned, if you concentrate in the bottom here, I summarized all of her history and exam in the bottom. It seems like 3 years ago, she had visual problem. A year ago, she had left leg numbness. And then now she has clumsiness and loss of balance. So 3 different lesions in different parts of the body separated by a whole year or 2 years in here. So these are called lesions in space and time, or lesions that are separated in space and time. And that is the only pathognomonic, if you will, presentation of multiple sclerosis. So the difference between MS and a stroke is that as MS starts, it smolders. It comes on over a period of days, and it goes away over a period of weeks. It doesn't just come on in 2 hours and then go away. And I see this a lot for that, oh, I have MS because I had 2 hours of dizziness and now I'm better. That's not MS. Usually MS symptoms come on for a period of 2 days, 3 days, and then they go away over a period of 6 weeks or so. Sorry. So the other thing that we encounter a lot in the emergency room in particular is this a relapse? That's usually the question. A patient has a diagnosis of MS. Someone has diagnosed them with MS 10 years ago, and suddenly the patient comes into the ED and says, I'm having a relapse, give me steroid. Now, we do go ahead and get browbeaten and give steroids, but remember that a true relapse, again, symptoms develop over days and resolve over weeks. Often there's a focal loss of function. In other words, there's no pain. I can't walk. My arm is twisted and so on. That is not MS. It's a loss of function. It's weakness, difficulty walking in particular, loss of vision. It's always an upper motor neuron sign. In other words, we have learned that from first year medical school, how to differentiate upper motor neuron from lower motor neuron. So there's always hyperreflexia and spasticity, not flaccidity. And there may be a recrudescence of old symptoms. MS patients have pain, but pain is not part of the relapse. And steroids can improve anything, including all these symptoms here or other symptoms. How do we diagnose multiple sclerosis? Well, basically what we have is a clinical, which is a loss of neurologic function, separated in space and time. And then there is imaging. MRI is the gold standard, is an important tool, and it's always positive. I know that I still haven't gotten to the point as to accepting the fact that there is what's called clinically isolate MS, meaning your MRI is 100% clean, but you have these symptoms and you have multiple sclerosis, or the other way around.
radiologically isolate MS, meaning that you have no symptoms and the brain has a few dead cells, and now you get a diagnosis of multiple sclerosis. I don't think any of those are 50% diagnosis. It could be, it could not be. And then often we invoke CSF to see if that is gonna arbitrate and take us to diagnosis of multiple sclerosis. The problem with CSF is that only about 50% of patients who come in with clear MS exacerbating, remitting type of symptoms and their MRI is positive will have a positive CSF. What's positive CSF? Well, you have oligochronal bands, or you have antibodies that are in the CSF that are produced in the CSF, and they're not coming from the blood. And we take these antibodies and we say, okay, the brain is inflamed. But that's about all you can say, really, that brain is inflamed. You can't say anything about whether this is MS or this is something else going on, or there's some other infection, inflammation going on in the brain. Laboratory testing, sending for blood and other things, is to basically rule out other inflammatory causes, for example, lupus. So there are McDonald's criteria in general. When we look at the McDonald's criteria and use that as a diagnosis for MS, it is mostly a quantification of disabilities. And this quantification of disability is basically for drug studies. So that if you have a number based on McDonald criteria and you give medication and a control group, how much a decrease in comparison of those two groups are. They really don't help in terms of either diagnosis of multiple sclerosis or how you're going to treat the patient, because everybody doesn't fit into McDonald's criteria. And again, the McDonald's criteria, you have to take it with a grain of salt and look at it as a study tool rather than as a diagnostic criteria. The other point is that MS plaques can appear everywhere in the brain and the brainstem and the cerebellar peduncle and the spinal cord. They are often in the periventricular area and corpus callosum, most often in the corpus callosum. And on the last picture on the right, the bottom of corpus callosum is really bright with MS plaques. And then finally, a contrast enhancement is in the shape of a C. It's here. Also, one other thing that you can do with the MRI is to look and see whether the lesions are relapsing, remitting, or the lesions are progressive, because by looking at one specific MRI at one point, you can make a determination of the timing of those lesions. Here's what I mean. On the left, and there is a T1. And this T1, there are these dark areas. These dark areas tell you that this area of brain has already gone into degeneration. So you have a degenerative phase of MS, and these lesions are very old. Now you have a flare here. With flare, you have a bright area here. This is not totally corresponding here, but there's a bunch here. You know that these are not as old as these, but they are not brand new either. In other words, they are a few months old or so. And then if you look at the picture on the right, this is a contrast. Contrast is telling you that right about here is only one lesion that is active, and that lesion is now progressing and active in the brain. So you have 3 ages of lesion: years, months, and then current lesion. So that tells you that this patient has had lesions in space and time, not necessarily by clinical lesions, but by MRI lesions. So you can use MRI as a diagnostic criteria to determine whether this patient has had lesions in space and time. And then one other thing that I mentioned earlier is this C-shaped contrast enhancement. The C-shaped contrast enhancement is a pathognomonic of multiple sclerosis, because we know that in abscess and tumor, the contrast enhancement is either full and complete or solid and junky, like as is in tumor. But in MS, it's C-shaped. Okay. So as I said, the diagnosis is done by clinical and imaging. We can throw in CSF if we need to. What about pathophysiology of MS? In terms of pathophysiology, the classic way of looking at pathophysiology is that when we see a clinical finding and we see a brain that belongs to that clinical finding, we want to kind of know more about it. So here's a brain of someone who has multiple sclerosis, and as I told you earlier, has very typical Dawson's fingers. See, that thing looks like a finger right here. And if you take a little piece of this finger and put it under microscope, what do we see? Well, we see these things. I know it's kind of 3 or 4 pink pictures, but believe me, what it is inflammation, because there's a lot of white blood cells in the brain. There is gliosis, because a bunch of glial cells are in here also. Demyelination is in there, and cuffs of white blood cells. If you dig that a little bit more, you see this picture. This is from Claudio Lucinetti, showing that in the top picture, these are macrophages that are chomping on myelin, and they're totally stained with myelin that they have been digesting. And they are making these little nodules here in the leptomeningeal area. And then around the vascular area, there are these cuffs of white blood cells. And the cuffs of white blood cells are made of either CD4 cells or CD3 cells. So they are getting inside in the vessels, and from vessels, they squirt out into the periphery, into the Verhoeven space, and from there, they disseminate into the brain. And finally, here is a very nice picture of demyelination. On the left, there is a normal oligodendroglial cells, and there is myelin that is wrapping around all these axons. So it's a cross-section of a nerve, and axons are myelinated by the oligodendroglia. Now, in an MS patient, you have the same thing, but you see that the oligodendroglia is very faint. And particularly, the most important thing is that some of these axons are not even myelinated. And then at some, the myelination is very puny as you look at these axons. So this demyelination is shown here in electron microscope. And this is a special staining. You see that axons are like wires. And in this wire, you literally see as if the insulation is ripped off. So the green is the axon, and the red is the insulation, and the insulation is kind of ripped off from these axons. Obviously, when that happens, the axon does not transmit the signals very well, and it doesn't function very well. We have always heard that it's a demyelinating disease and it happens only in the white matter. And the truth of the matter is that that's really not true. When demyelination occurs, it can happen in the gray matter also. Now, do remember that the gray matter also has a lot of myelin, because all those neurons have to connect with other neurons via the axons, and those axons are mostly myelinated. So this was another discovery in 2011 or 12 that was done by Lucinetti, showing that indeed plaques can be extending into the gray matter, not just the white. If you go below microscope, so these are microscopic findings that we have. If we go below microscope and look at molecular analysis and chemical analysis, we see those 4 things that I told you, but also there are a bunch of immunoglobulins, there are complements, there are various cytokines, interferons, particularly interferon gamma, tumor necrosis factor, transforming growth factor, and so on and so forth. So there are a whole bunch of other chemicals that are involved. And these chemicals form a symphony of chemicals in the sense that in order for them to generate multiple sclerosis plaque, some lesions or some chemicals come on, others go back, others kind of pitch in, and the others come back, two of them come back, and so on. And that coordinated attack eventually causes the plaque formation. I know this is a little bit busy, but I didn't have any other way of looking at it, and I assure you that I'll make this very simple. This is basically the basic immunology. And the reason this is important because as a neurologist or as PAs or as other neuro healthcare providers, we always diagnose and write prescriptions for these medications. So we ought to know at least where they are working. So if you look at this mainstream, there is an antigen exposure that activates B lymphocytes. B lymphocytes activate T lymphocytes. T lymphocytes come out of the lymph nodes. They go into the bloodstream and clonally expand. From clonal expansion, they cross the blood-brain barrier. They activate microglia in the brain and cause inflammation in the brain and then cause tissue damage. This red arrow here is basically this whole thing goes back and start all over again. This is the maintenance arrow. In other words, you trigger and you produce a disease, but then you maintain it. And here and there, this arrow kind of comes back and starts new plaques for you and new lesions in the brain. So this is the cascade of events that causes multiple sclerosis. And as you can see, most of it up to here, the first four steps are in the periphery. So let's kind of look at this as acts in a play. What about the initiation? What initiates it? Well, the initiation is a trigger. A trigger comes into the body and activates the reticuloendothelial cells or B lymphocytes. And then these B lymphocytes activate the T lymphocytes. What are these triggers? These triggers could be unknown proteins. I was telling you earlier about the infant hygiene hypothesis. And there is Taylor virus, canine distemper virus, JC or John Cunningham virus that causes the causative agent for PML. This also has been invoked as a causative agent for multiple sclerosis. And most recently, in fact, in January of Science, there was a very long and well-studied 30-year, actually 40-year study showing that Epstein-Barr, which is a herpes virus, is possibly a causative agent for multiple sclerosis. And this was by Björvik in Science in 2022. So as I was saying earlier, a virus comes up every few years as a cause for multiple sclerosis. But in general, as a clinician, I think we think of all of these as being possible factors. And they're not 100% factor, but partial factors. In other words, everybody who has canine distemper virus doesn't get multiple sclerosis. Maybe only about 20% of them do. Everybody who has Epstein-Barr virus is not going to get multiple sclerosis. Only 30% of them do. As I said earlier, these antigens come in, and obviously the first confrontation that they have are A, the reticuloendothelial cells, and B, the B lymphocytes or CD4 lymphocytes, T4 lymphocytes also. So B lymphocytes and CD4 lymphocytes are kind of important things that come in at the very beginning, and their main function is to activate T helper cells. And these all happen within the lymph node. So B lymphocyte is going to activate a T helper cell, and T helper cell is now activated and primed to respond to that particular antigen. So as a consequence, they work as a offending agent. The T lymphocytes or these B lymphocytes can be suppressed by these medications. They're very fancy names, but all they do is basically they kill CD20 B cells. So ocrelizumab, rituximab, obinutuzumab, ofatumumab, all of these kill the B lymphocytes. And the reason B lymphocytes are important is because if you look again here, they are antigen presenters, they produce cytokines, and they produce antibodies. All of these activate these T cells, the green cells over here. And these green cells are the effector cells. These green cells, after they are activated, or CD4 cells, which is helper cells, they have to egress from the lymph nodes and go into the bloodstream. That egress happens through a molecular dance with sphingosines and sphingolipids. And what stops the sphingolipids are these medications, which are Gilenya, Ponvory, Myzanta. I apologize, I can't pronounce all of them. I can pronounce one or two of them, okay? But these are the category of medications that slows down the egress of lymphocytes from the lymph node. So it does not do anything in the brain. It basically goes into the lymph node and tells the lymph node not to release these activated T cells. In Act 2, once these T cells are activated, so the first we talked about is an antigen comes in, activates the T cells, and there are some medications that we can stop this activation. In Act 2, these activated T cells enter the bloodstream. So now they're circulating. So here's a white blood cell or lymphocyte. They're activated in two forms. We all know that there are so-called bad inflammation if there is Th1 and Th17 is activated. If there is Th2 and other T cells are activated, then that's good inflammation. The bad inflammation causes destruction. The good inflammation causes rebuffing of the bacteria and other things, and also help in healing. They also come along with a number of chemicals that are associated with them. So there's a whole halo of chemicals that come along with these white blood cells in the bloodstream. And as these cells come into the bloodstream, you can suppress those cells by giving these small molecules, which is dimethyl fumarate and droxymal fumarate. Basically suppresses all of these cells, but presumably mainly the bad inflammation. So it restores a balance between the bad inflammation and good inflammation. So the medication like Tecfidera and Vumerity works by suppressing T helper cells and restoring the balance between the bad T helper cell and the good T helper cell. In Act 3, activated T cells cross the blood-brain barrier. I think one picture is worth 1,000 words. If you look on this left upper picture, you see a white blood cell, and that is the lumen of a vessel in the blood-brain barrier. You see that this white blood cell is squirting through and getting out of the lumen of the vessel into the Verhoeven space. Obviously, it's not that simplistic. There is a huge molecular dance that has to happen before the cell can squirt through the blood-brain barrier into the brain parenchyma. And those molecules are really important and represent points of intervention. The points of intervention that they represent are these chemicals, Natalizumab, which is Tysabri, or Daclizumab. And what they do is they do not allow the activated T cells to cross the blood-brain barrier. Okay, with each one of these steps that I keep telling you, they all look great, but the problem is that they're not very specific. They stop the good T helper cells and the bad T helper cells from crossing the blood-brain barrier. So when they stop the good T helper cells from crossing the blood-brain barrier, they will cause things like PML. Such Tysabri can cause PML, and we have to look for John Cunningham virus and test all of these things in order to make sure that they are not. And then we are getting to that point that you're going to ask me, well, what about the efficacy? Which one of these are better for this? And the answer to that is really all of them are the same. If you look at the drug at the initial certification by the FDA of each one of these 15 or 17 drugs that I pointed out, they look at relapsing, remitting multiple sclerosis, and they count the number of relapses. And if it's decreased, then great, that drug becomes a viable drug and is for sale. One is better for the spine, one is better for this, one is better for this. It is not. There's no magic in there. Just pick a poison and that's what is going to be in here. Okay. What about then once these T cells or B cells cross the blood-brain barrier, get into the brain, then what happens? Well, remember I was telling you earlier that there is a hand-in-hand march between the peripheral immunity and the central immunity, and that's exactly what happens. So these T cells, which is Th1 and 17, and then Treg cells, which is Th2, both of them cross the blood-brain barrier. If Th1 and Th17 is dominant and is activating microglia, it produces what's called M1-like microglia. These are bad inflammation. So these cause neurotoxicity. So these microglia can cause terrible neurotoxicity. Whereas if you have Treg and Th1, these are T helper cells. They activate the good microglia. They cause neuroprotection. So you see that there are so many areas where there is a balance between the good T cells and the bad T cells, the good microglia and the bad microglia. And this balance between them is sort of the most important in terms of keeping the homeostasis. It is not autoimmunity or non-autoimmunity, it's the dysregulation of immunity between them that causes this dysregulation. I'm going to skip that. It's the same that each microglia comes with a halo of chemicals also. And finally, we're going into damage into oligodendroglia. So the first step, once the T cells and B cells and all of these cells get cross the blood-brain barrier, they start attacking the axon. So on the left side, you see that there is complement here, there is cell-mediated immunity, there is T cell here. So these cause disruption in the environment of the axon. And there's a bunch of them here also. So macrophage with complement, there are antibodies come from B cells, and then the T cells or CD8 cells come in. And what they do essentially, not necessarily a complete attack, but they disrupt the milieu of an axon, okay? I keep emphasizing that because that's what happens here. Disruption in the milieu of the axon disrupts the structure of the axon. How? Because axons and their myelin are put together kind of like a Jenga tower. You have all these sodium channels, you have the potassium channels, these produce charges. The charges produce just enough attraction, repulsion to keep the myelin wrapped up around the axon. And as soon as the environment is disrupted on the right side, you see that all the sodium channels and potassium channels are kind of off from their position, and that disrupts that charge. So charge changes, and the charge is what's really important for integrity of the axon and myelin. So the molecular pathophysiology of demyelination essentially is disruption and the charge around the nodes of Ranvier, and as a consequence, those nodes of Ranvier are going to slough off and open up. And finally, you also get what's called axonal damage. So once we have the myelin damaged, the axon is left naked in here without the myelin, and the myelin becomes damaged. So this is what we call the degenerative stage or phase of multiple sclerosis, where degeneration sets in because the axons are now dying and disrupted. So we already talked about that. Now, if you go back to that busy slide, we talked about all of these where T lymphocytes are activated. We need anti-CD20 monoclonal antibodies to give here. Beta interferons will suppress T cells and activation of T cells expansion. Anti-sphingolipids, for example, Gilenya doesn't allow the T lymphocytes to egress from the lymph nodes. Small molecules suppress the T lymphocytes in general. Then we have monoclonal antibodies such as Tysabri that blocks the crossing of the blood-brain barrier. And then we have monoclonal antibodies that can hopefully eventually work straight into the brain itself. And then the maintenance, as I was talking about, comes because of there's again a whole bunch of different factors, including genetics of oligodendroglia. So there are certain oligodendroglia that can die off and release their protein, and then those proteins can start this whole thing all over again. Or there are oligodendroglia that do not die off, and this is also for an explanation for a single shot disease versus a disease that's smoldering and continuously going, is that once the damage to oligodendroglia is done, the proteins that are released from the oligodendroglia goes back and restarts the cycle here. Let me skip that. So in terms of treatment, I think pathophysiologically I mentioned everything, but there are a couple of generalized comments. We always talk about disease modifiers. If you really go and dig up into the literature, the MS medications in general are symptom modifiers, are medications that modify the relapse from 4 times to 3 times. That has been the standard from the time that beta interferon came in the late 1990s until now. The disease modifier concept came about because of the post-marketing studies. And obviously, when you call it disease modifier, it has a lot more psychological effect than symptom modifier, because a lot of people don't have a lot of symptoms. And why do you want to give them medications? And unfortunately, a lot of the so-called thought leaders in multiple sclerosis fall for this, and they talk about disease. But the point I'm making here is that the MS drugs in general, they're $70,000 to $80,000 a year. They're only symptom modifiers, not disease modifiers. In terms of their availability, they are available in injections, for example, beta interferons. They're oral drugs that are small molecules and that are pills that you can take. And then there are infusions, which are monoclonal antibodies. A lot of it is, I would probably go by the fact that if the patient, which one works for the patient in terms of convenience rather than anything else. So these are just basically beating the same horse. I'm gonna stop here and at this slide and say that there are some new monoclonal antibodies that are coming in that will work on the other side of the blood-brain barrier, but they are not around yet. And then if there are any questions.
With Dr. Azizi, thank you very much. It was excellent. Actually, it's, you know, I do understand that probably it was even some areas oversimplified, but that's what people really need to really start understanding about all these medications, because there are so many medications coming on that everybody's getting confused. We do have several questions for you. And I'm just gonna go one by one. So we have come a long way from the platform ABC drugs. What guidance do you use in choosing among the newer drugs for multiple sclerosis?
So the question I'm going to ask you is that have we? The reason we think that we have come a long way is because we have gone to all those different nodes that I outlined, and we attack those different nodes. Are they any better than ABC drugs in terms of symptom modifications, or rather, in some ways, yes, because there's not a lot of side effects. You take a pill, you're done, or you get an infusion every 6 months, that's great. But in terms of disease modification or cure or other things, we really haven't moved that much. The guideline that I would put forward in terms of which medication to use would be, I would start with the simple. There's not a lot of science in terms of which patient is going to need which one of these medications. We kind of pick something off the shelf and we say, oh, there was the small paper, 20 patients showed that this medicine is really helpful for spinal lesions, for example, Egress. There was a post-release study of like 30 patients or so showing that Egress is good for spinal lesions, and that gets stuck, unfortunately. There's no controlled trials to show that indeed that works. But the guideline is that a lot of times our guidelines in terms of MS medication is guided by the insurance companies. They have contracts with the drug companies, and then they will say, okay, we are going to cover this, but not that, and so on and so forth. And you go and fight with them and say, no, this is better. Problem is that the reason that they are able to do that is because we really cannot prove that this is better. Let's say Ocrevus is better than fingolimide for this one patient. We can talk about side effects, and we can talk about an ability to eat, or we can talk about the ABCs as the site of the injection that's causing major problem. But those are sort of the way you progress, rather than having. So each one of those are a tool, and they should be deemed as a tool. None of them are sort of the golden arrow that's going to kill the bad goose.
Next question, and I think you already touched a little bit. Now, the difference in risk between the oral medications, injections, infusions, or which ones are the riskier, and which ones are less risky, if we can even look at the medications like that.
So that's funny. The oral injections and infusions, each one have, there are multiple medications. Let me just go back. So there are multiple oral medications that have multiple mechanisms of actions. And the risk is determined by where they go and where they do. In general, I think until Tysabri came, MS community was very complacent about these medications. We gave potent immune modulators, and then nothing happened, and patients did very well. And I think subsequent to that, the same thing has happened. With the exception of Tysabri, the rest of the medications in general are pretty good if you go by the guideline. So the medications that are anti-sphingolipids, for example, Gilenya, And you have to make sure that there is no cardiac issues with those patients. And then once you did that, everything is going to be fine and patients tolerate them very well. So per se, what I'm trying to say is that per se, the oral medications are no less risky than infusions than injections, because within each one of those groups, there are different mechanisms of actions. In other words, within the oral group, you can find something that suppresses T cells. Within the infusions, you can find something that suppresses T cells. And within the injections, obviously, you can find things that suppresses T cell.
Next question. I have had 2 patients with symptoms and MRI scans suggestive of multiple sclerosis who had greater than 5 oligoclonal bands in their CSF and serum. How would you interpret that finding?
Well, as I said, I don't put too much value on the oligoclonal bands, just because all you're looking for in there is basically, is there inflammation or not? And if it is oligoclonal band, is the inflammation against one single antigen? That's the assumption that MS is coming because there is one single protein goes and activates your T cells and produces one set of antibodies. The problem is that that may not be true. MS may be a completely heterogeneous disease, and even in a single person, there may be 2 or 3 or 4 antigens in there. So if you have more than 1 or 2 oligoclonal bands, all it tells you is that, yes, there is inflammation. It really doesn't tell you anything else.
And as you said, I think during your talk, that imaging has way more weight than the CSF in diagnosing. All right, we're at the hour.
Historically about that, I'm sorry, Peter, is that the time that oligoclonal bands and analysis of CSF and to serum ratio and all that was, for some of us old geezers that remember that was when MRI wasn't even there. The CT scan looked like a dark hole in there and you couldn't see anything. So one of the things that you would have to go for these people who were very disabled, you would look and say, oh, is there inflammation in the brain? These were young people and they had, and then you found inflammation and you say, yeah, it's probably multiple sclerosis.
We're at the top of the hour, but I'm going to squeeze in one more question. What about the management of clinically isolated syndrome or radiologically isolated syndrome? Do these people, is there an indication for the immunomodulation in these patients?
Try to be as conservative as possible. That would be my recommendation. And I can back that by telling you from my friends in Europe and England and all that they don't even want to pay for different kinds of MS drugs. Conservative means that if you don't have both of those in there and you don't have a definitive diagnosis of multiple sclerosis, then be conservative and wait. All you have to do is wait 6 months, literally, because if you don't start the medication and 6 months later get another MRI, if there are more lesions, that will force your hand, or if the patient comes in. Now, the problem with clinical isolate is that a lot of times we deal with pain. And pain is not, it is inflammation, it is part of the multiple sclerosis and so on and so forth, but it's not necessarily a clinical symptom of multiple sclerosis. A clinical symptom of multiple sclerosis is loss of function. Loss of vision, loss of motor, loss of sensation, loss of balance, and so on and so forth, just like a stroke, except that the time course is different.
Dr. Azizi, thank you very much for another great talk. I'm getting a lot of positive feedback.
Thank you.
Again, thank you very much and have a good day.